my invitation was for an interesting case. And can I have full screen, please? And I'm going to show you a TAV implantation, but in a different position. So we have a 62-year-old male. He was presented with severe AI due to bicuspid morphology. He has a very large, enlarged left ventricle and a reduced ejection fraction. And he presented also with complete AV block, in turn with episodes of 2-to-1 block, and with an LBB pattern with a QRS duration of 174 milliseconds. So his treatment he received, initially he had a CRTD implantation, and 1 month post this procedure, he had a SAVR with Inspiris Resilia 25 millimeters, and an MR valvuloplasty with Edwards Physio 2 ring 30 millimeters. So this is the preoperative transesophageal echo. And this is the immediately post-surgery inside the operator room, his transesophageal echo. So the patient was doing fine. He is asymptomatic. He is very active, but in serial echocardiograms, we just noticed that the LV has already, that was already reduced in size and volume, started to enlarge, and we detected severe MR. This is his transthoracic echo from October 2023. You can see that, you can appreciate that something is not going well with the mitral valve. And we depicted this with, again, with transesophageal echo. The patient had a right heart catheterization, nothing special to mention. And we decided to proceed with the mitral valve in ring procedure. So he has a Physio 2 ring. There are available, I think, at least 20 rings for the mitral valve, and we have to keep up in line with the valve-in-valve application. This patient has a complete semi-rigid ring that has excellent radiopacity, and the semi-rigid rings of this patient achieve a good balance of circularity at the anchoring of the valve. So we did also a phantom implantation. We have to address that 12 millimeters of the balloon expandable valve is protruding to the LVOT, but this patient has enough space for the new neo LVOT that we are going to create. So procedural plan was in the hybrid room under anesthesia, echo guidance, of course. It is very important and crucial for the procedure to check the deployment view before preparing the patient, and of course to confirm that the radiopaque objects are not overlapping in the field of interest. So vein sheath, transeptal, let's skip these steps because I'm going to show you. This is the operative day. You can see also that he has also a paravalvular leak from his aortic Resilia valve. So this is the projection that we decided to work, as long as we have a perpendicular the ring. The transeptal puncture was done standard with a BRK1 needle. We have much more space, let's say, in spite of the tier transeptals. Then we cross with a wire to the pulmonary vein, and it was quite easy to advance a pigtail catheter through the valve, as you can see from the 3D echo. So we placed the Safari XS wire, and we did a septostomy with a 14-millimeter balloon, and not above 2 atmosphere. We have to be very patient here in order not to leave with a big atrial septal defect the patient. You can see the septal defect that we created to implant the valve, and you can see here the atrial septal defect, very nice image. So we are going to implant the Sapien 29-millimeter valve in this 30-millimeter Physio 2 ring. Of course, the skirt of the valve now is placed atrially. Just before we implant the valve, we did a rapid pacing. We used the wire for the rapid pacing to see if we have any peculiar movements in order to, when we inflate the valve. And this is the inflation. Fortunately, we have a conical deployment because parallel deployment is related with embolic risk embolization. And we try to be 20 to 30% atrial to the band. So this is the inflation. The patient had an extra systole, and I think the valve moved a little bit to the atria, but you can see the result is nice. This is immediately post-implantation. You can see the paravalvular leak of the valve. So we decided to make a post-dilatation. I don't have the image, but again, the transesophageal image is very interesting. If you see the stent frame of the Edwards valve, I don't know if you can notice with the yellow arrowheads, the distance after post-dilatation was a little bit, the stent frame reached the frame of the ring more, but that was enough not to have paravalvular leak. So this is final result, I think an excellent result. This is the 3D image. No paravalvular leak. And this is his follow-up, just his follow-up 10 days ago. The patient is doing well, and he's going to travel to Machu Picchu. Thank you very much.
Okay, very nice case, very nice case. Any comments from the moderators?
What, may I, Adonis, it's me. What about the septal, the atrial septal? Did you do anything there?
What about?
The septum, the septum. The septum. After the transeptal puncture, if you
No, we didn't do anything. Usually, okay, when you inflate in 2 atmospheres, you don't have deterioration. And we measured the pressures, but we didn't do anything.
Okay.
You can use a 12 millimeter balloon, but normally we use 14 if the valve is 29 millimeters.
Compared to valve-in-valve procedures, really valve-in-ring is a very hard procedure, and congratulations for this case. You also measured neo-LVOT measurements before the case.
Yes. Yes.
So it's also very important.
Yes.
Because risk of LVOT obstruction in that kind of cases, we use lampoon procedure, you know. And what I observed also, when you make the post-dilation, the distal part of the balloon also go to a little bit to the LVOT, and then that finding was the enlargement of the valve also seen very good.
I think it was, yes, that was a good point. This is a good point, Dr. Kilic, and that was the reason that we didn't have any paravalvular leak afterwards.
Congratulations.
To tell you the truth, I was expecting the 1 month follow-up because of, let's say, late migration of the valve might happen, and I was very skeptical about this, but the patient is very well.
Perfect. Dr. Tsalamandaris is a master of PFO and ASD closure, so any tips about the transeptal, when did you have to close this?
It depends of the size of the defect that we created. As I saw in the TE, the defect is not very big, so there will be any problems from now on. Another thing that I want to say is that I have with Professor Doudoudas an experience with valve in ring, in mitral ring, and I remember very well that there were also a para-ring leak, and the native scalps of the mitral valve helped us to close this paravalvular leak. We put also a sapient valve in, with the same procedure as Dr. Arampatzis did, and we were very lucky from that with the first step, the native valve, the native scallops of the valve closed the paravalvular leak. Excellent job.
Just, if I may, one comment. We try initially to puncture the transeptal with a needle, but because of the previous operation, it was very hard, so we used the surgical cut down.
So